How's it going, guys? Past level question for renal for step 1 surgery, internal medicine, 2CK. 40-year-old woman, post cholecystectomy in hospital. She has a history of rheumatoid arthritis. Physical exam shows a faint maculopapular rash. BMI 30. Vitals normal. Laboratory studies are shown. Normal hemoglobin 14 grams per deciliter. Should be 12 to 17.5 menstruating women, 13 to 17.5 non-menstruating women and men. Sodium normal 140 should be 135 to 145. Potassium normal 3.9 should be 3.5 to 5. And then we have 1 plus protein, 1 plus RBCs, 2 plus WBCs in the urine. Which of the following most likely responsible for the patient's findings? Let's just hop to the answer choice here. Choice A. Amikacin, wrong fucking answer. It's an obscure aminoglycoside that I'm not trying to be fancy, slick, or creative. This shows up on one of the NBME forms causing acute tubular necrosis, and students get it wrong because they don't know what it is. Okay, so aminoglycosides, acute tubular necrosis, muddy brown, dirty brown granular cast, brown pigmented cast, they can say in 50% of questions. The other half of questions, they're not going to give you that descriptor, but they're going to tell you classically that a patient had ischemia. That's the ultra high yield cause of ATN on USMLE. So I could have given you the same question here, and rather than having made it about pharm, I could have just said she lost blood during surgery, she was resuscitated, or she had a 30-second episode of low blood pressure during surgery, was resuscitated, and then 2 days later in post-op, she has oliguria, increased creatinine and renin, and BUN, and the answer is just acute tubular necrosis, not pre-renal. I've harped on this in my renal PDF. Obviously, I'm going to link it down below, but you need to know acute decrease in perfusion of the kidney causes ATN, not pre-renal. It's because the PCT is most sensitive to anoxic injury due to the high concentration of ATPase pumps, so it sloths in the acute setting, whereas more subacute to chronic, NSAID, diuretic use, general dehydration, those aspects will tend to, or those elements will tend to cause pre-renal. So ATN, wrong fucking answer. Choice B, cefazolin, correct answer. So you need to know diagnosis here is interstitial nephritis, aka interstitial nephropathy, aka tubulo-interstitial nephritis or tubulo-interstitial nephropathy, all the same thing. Now, this is going to be classically an NSAID, beta-lactam, or cephalosporin, or a sulfa drug such as allopurinol. The latter is on one of the new NBME exams, followed by white blood cells in the urine, plus or minus a maculopapular rash. Only about 50% of questions are going to give you a rash. You can't rely on it as a crutch. But this is essentially an allergic reaction of the kidney. That's what this is. So these are eosinophils in the urine. They can just say straight up, eosinophils in the urine. Instantaneously, you know the answer. Or they can just say white blood cells. They do either, okay? Now, this is about 4 out of 5 questions, okay? 4 out of 5 questions. Beta-lactam, NSAID, cephalosporin, sulfa drug, followed by white blood cells in the urine, they're eosinophils. And I said a rash, only about half of questions. 1 out of 5 questions, they'll just say patients on an NSAID, beta-lactam, cephalosporin, or sulfa drug has mild proteinuria, hematuria, no other findings. And the answer is just interstitial nephritis. And you can eliminate the others to get there, okay? So just be aware that's on one of the NBME exams as well. But this is the classic presentation here. So cefazolin, it's a first-generation cephalosporin, classically given intravenously. Oral equivalent is ceflexin, okay? So could have said NSAIDs, as I said, indomethacin, naproxen, diclofenac. Could be nafcillin. That shows up one of the NBME forms. They tell you patient was treated for endocarditis for 6 weeks on nafcillin, has eosinophils in the urine, it's just interstitial nephritis. Let's just hop to the other answers here. Choice C, gold salts, wrong fucking answer. These are an antiquated medication for rheumatoid arthritis, still used in parts of the world, such as India, and they can cause membranous glomerulonephropathy. It's a nephrotic syndrome. So gold salts, dapsone, sulfa drugs as well. Okay, so if you had, I mentioned before, allopurinol, sulfa drug can cause interstitial nephritis, the eosinophils in the urine, right? Well, what if we had given you allopurinol plus 4 plus proteinuria? And that's it, right? So we have a nephrotic syndrome. That'd be membranous glomerulonephropathy. So wrong fucking answer. Choice D, gentamicin, wrong fucking answer. And the way you know it's wrong is because amikacin is also an aminoglycoside. So gentamicin, tobramycin, amikacin, just harped on it. Wrong fucking answer. Choice C, intravenous contrast, wrong fucking answer, because this is contrast nephropathy is ATN 19 out of 20 times. Okay, so what you need to know for 2CK, the only detail they test actually is that the way to prevent contrast nephropathy is adequate IV saline administration prior to any type of CT with contrast. Okay, there's some other studies as well, but it's usually CT contrast. You just need to adequately hydrate the patient. That's how you can prevent contrast nephropathy. In this case, wrong fucking answer. You know the deal. To make more content. If you like my stuff, subscribe my channel. I appreciate your time. That's it.